First of all, I thank the organizers for giving us this opportunity, and without wasting much time, I request Dr. Raju Shah sir, our first esteemed panelist, a very senior pediatrician from Gujarat. You don't require introduction to this crowd. He already was introduced prior. Dr. Satish Sharma is there. He was to leave at 12:15. I think he has left.
I think he has train at 12:30.
So, yes, so I request Dr. Himanshu Tadvi, my junior friend, again from Vadia Group. And he's a senior pediatric intensivist from Surat, practicing for almost 15 years, I suppose. Is that Himanshu right? Almost, right? And a brilliant student who is come with Vadia Fellowship and established very nicely as a pediatric intensivist in Surat. And third is Dr. Minaj Sheikh, again a very good friend of mine from intensive care group, a very active person and very kind of a dependable guy in a pediatric intensive, we call it. Give him any job and he will do it to his most perfection. He's at Lilavati Hospital, Mumbai as a pediatric intensivist and senior pediatric consultant and DNB teacher. So without wasting much time, let's move to this storm, the cytokine storm. I'm sure 33 years ago when I passed my MD, this terminology was not coined, and I used to read my Nelson textbook. In that, HLH was mentioned after histiocytosis. I remember there was a small chapter on histiocytosis. In this first was histiocytosis, then HLH, and HLH was given just about 4 lines in that. That Nelson textbook must be about 4th or 5th edition of it. And we were not knowing. And perhaps this coin, Dr. Ajusha also will accept that this is something which has come up in last about 2 decades. We started noticing that. And almost 22 years ago, one of my adult physician friends' daughter, she landed up with the dengue, deteriorated, landed up in Hinduja hospital and went on to require almost 22 platelet transfusions. The hematologist was not knowing what to happen. Dr. Mohan Agarwal came from Bombay hospital on request. He collected a smear bone marrow and he said, give him steroid. This looks like macrophage activation. So that was our first introduction to that. And then it went out, and now today almost we are astonished to see how many cases in ICU are coming with this diagnosis. And that also makes me shocked how many patients we must have lost with the misdiagnosis of deteriorating sepsis without diagnosis because of HLH. If I look back in retrospect, I'm sure we must have lost many patients with that diagnosis. So that brings me to this case. This was a 10-year-old boy admitted to primary pediatrician with a history of fever for 2 days and was confirmed NS1 positive dengue. He was stable for next 36 hours, and then this 10 p.m. on the second day of admission had sudden severe headache with fever spike of 102, in fact went on to become 105. He rapidly, the pediatrician was staying, this is a peripheral pediatrician, a place called Roha, and the pediatrician is to stay on the second floor of the same building. So he was called by the sister at 11 o'clock, sir, ye kaisa dekh raha hai, dekho. So rapidly deteriorated in next 6 hours, he went into shock. Progressive encephalopathy. This child was literally eating on his bed at 9 o'clock, and this whole story is of the last 4 hours. So, Raju Shah sir, what do you think is the likely cause of this on the background of dengue?
Yeah, I mean, as we all know now, that any such condition where, if the child is doing well, and after about 5 or 6 days of illness, child starts worsening. Probably something wrong is going on in his immune system. So probably this child has started developing immune dysregulation or something related to that. And we have to think on that line and start investigating so as we get the idea of what is happening.
Right. So basically he was intubated. I'll come to you again. There are a lot of things I'm sure you're going to contribute. So he was intubated and shifted to the tertiary care. It required 2 hours of transport. He reached the tertiary care pulseless. His he was intubated. GCS was just 5. And a detailed evaluation revealed severe myocardial dysfunction. Ejection fraction was just 10 or 20%. So what's next, Himanshu? He comes to you with this situation.
So basically, the sudden deterioration on 4th day of dengue, it may be a dengue hemorrhagic shock. There may be sudden bleed intracranial, and besides that, some immune mediated reactions. All are possible. As this child is already intubated and he is having severe hemodynamic instability, so supporting airway breathing and circulation is our prime management goals, and improving the circulation, and management of raise ICP as child GCS is also very low. So if possible, after stabilization and further detail organ assessment and neuroimaging fastest.
How often this kind of child you could stabilize in your ICU?
This require lot of efforts, at least 6 hours constant effort to stabilize them to fit for neuroimaging, to be fit for neuroimaging.
Perfect, perfect. So as you rightly said, but he further deteriorated. By the time he reached us, he was pulseless, as I said. We had bedside echo, myocardial dysfunction was there. So since it started with the encephalopathy, in that condition also we arranged for an MRI. And Minaj, this was a MRI.
Well, this is a very challenging case. A child case has been referred in a very difficult scenario. Having MRI, this seems to be like, acute febrile encephalopathy. Beyond encephalopathy is inflammatory process. So this is sometimes some types of necrotizing encephalopathy. We don't know, mostly inflammatory in this scenario, but infective cause have to be ruled out. But having said inflammatory is on the card first. So this is what I would say in this case.
So this was a hemorrhagic necrotizing infarct in the thalami, and this is a very challenging and very rapidly deteriorating condition. Believe me, they give not more than 12 hours to save them. If you know this condition, you diagnose them very fast, you promptly move with steroids, IVIG. By that time we had got his investigation, ferritin was 7,500, fibrinogen low, HGOT-PT high. So the diagnosis was made, he was received IVIG, steroids. We could not get an access to tocilizumab. That's what is recommended additionally. There is a big study from Hyderabad who says 40 cases they tried, and then hardly about 10 of them could be survived, but the morbidity is defined. So this one condition you pray God that you don't face in your clinical practice, because half of them, most of them, many of them would die without a diagnosis, and if you happen to save them, they will be left with significant morbidity, and this is called as acute necrotizing encephalitis, ANEC, which is a hemorrhagic necrosis of the brain, and it's a very stormy condition. And believe me, every year we see about 3 or 4 cases. I'm sure Himanshu, you also, sir, you also must be seeing a good number of cases. So that brings me to the basic question, Minaj, what is cytokine storm and what is the pathogenesis in that?
Well, cytokine storm is an umbrella term which take into account many things. In brief, this is excessive inflammation, hyperinflammation. Rakshak shi bhakshak ho gaye. So this is in brief. So all those inflammatory process which should be, switch off is continuing. So there is trigger, and after the trigger, that inflammatory process is continuous, which should have been otherwise, because of negative feedback effect, should have come down, is continuing. The pathogenesis reasons may be inflammatory, non-inflammatory, and then what is called as pro-inflammatory and anti-inflammatory. So this balance is lost. So this is immune dysregulation. In brief, immune dysregulation, where is there is excessive pro-inflammatory and there is less of anti-inflammatory. So then you have detailed pathogenesis. We have different types of receptors, and then NK cells and your helper cells. They are into actions, and a lot of your cytokines and released, and then they are causing the organ dysfunctions. So you have one side, you have inflammatory process. This inflammatory process is causing organ dysfunctions. So all organs can be affected practically. So in brief.
So to understand this subsequent maybe 25 minutes panel discussion, I made a small kind of cartoons and this. Sir, you want to say something?
Yeah, I just wanted to add that, initially when there were different terms used for different type of pathogenesis that was happening. That like dengue and all these, we call it HLH, while in some of the rheumatological conditions, we call it MAS, that is macrophage activation. Similarly, there were 2-3 all different type of conditions or names were used. So to keep it as, combined together, this new term, that is a cytokine storm syndromes, has been coined, and that includes all these under the umbrella of that name. And so it becomes easier. And one can understand the pathogenesis that these, though they look same, they are different. And there are different types of cytokines, they make different type of pathogenesis. And that is why sometimes the therapy also differs because of that.
So what Raju said is right, but to understand this subsequent session more, I request a very careful attention to next 3 or 4 slides, which will give you a proper understanding of what we are heading for. So I have made some interesting cartoon here. So imagine any pathogen is entering your body. You have got a adaptive immunity and innate immunity. Innate is with everybody, adaptive is secondary to your prior stimulation. So this pathogen will enter and macrophages will kind of engulf this pathogen. Not essentially it will be killed, it will stay in the macrophage. Once it goes inside, the pathogen associated molecular patterns and damage associated molecular patterns are projected on the surface of the macrophages, which will stimulate your innate immunity, the NK cells, and which will also stimulate if there is existing adaptive immunity by stimulating the T cells in the lymphocyte. Now I am not trying to make it as simple as possible. In either case, whether it is NK cell or T cell, this will induce a production of cytotoxic granules which are called as granzymes and porins, which will enter the macrophage and that will stimulate the macrophage to kill the pathogen inside as well as to cause the apoptosis of this macrophage. But simultaneously, this T cell and NK cell produce lot of cytokines which are of various types. So it could be IL-1, IL-2, IL-8, which will be pro-inflammatory, or it could be IL-10 which is anti-inflammatory. And this cytotoxicity and cytokine release is proportional. What do I mean? When cytotoxicity is produced, same time this is, so inflammation is created by these cytokines. And they are proportional. So as soon as there is destruction of the macrophages, the whole cycle cascade will stop and inflammation is well controlled. Cytokines are pro-inflammatory and anti-inflammatory to optimum controlled inflammation. As long as this is understood, so you have got innate immunity and adaptive immunity will work hand in hand to have an adequate control of this inflammation. Now what happens in case of cytokine storm, a pathology? So it could go wrong somewhere here where there is excess of trigger, which could be a severe infection like in a dengue, connective tissue or autoinflammatory mechanism. It can be defect in the NK cell or T cell mechanism, wherein there could be a congenital defect in the T cell NK cell function like congenital HLH, which we will be discussing. It can be acquired defect in a T cell or NK cell, which could be acquired HLH, which will get in case of dengue infected or infection induced HLH. It could be reduced T cell. This is what we more often see in sepsis. It could be decreased number of T cells or NK cells, or the cells itself will be dysfunctioning. So there will be less of cytotoxicity and more of cytokine, and there is a dysregulation, what they said, or it could be loss of negative feedback. I suppose these cartoons will make the understanding much simple to understand our future topic. And through this, those cytokines will stimulate the macrophages to cause hemophagocytosis, which we see very commonly. Hemophagocytosis, RBCs are killed and destroyed, which will increase the ferritin level, which is the hallmark of this, plus the inflammation will increase the ferritin. It can cause activation of plasminogens, so consumption of fibrin, so fibrinogen levels are less. It will cause suppression of lipoprotein, so thus high hypertriglycerides. So that's the whole basic concept of hyperferritinemia and hyperinflammatory syndrome that will get in case of cytokine release syndrome. And just now, as Dr. Raju sir said, this is the umbrella term under which you will get multiple pathologies. So may it be a congenital HOH, acquired HOH, autoinflammatory disorders, ARDS itself is a kind of a cytokine storm. So everything will come under that. The CRS is actually cytokine release syndrome, which we see in malignancies. So just with this brief introduction, let's go into more details with our expert. So Raju sir, who are more susceptible to these cytokine release syndromes?
So it all depends upon the now number one is certain type of infections can lead to those, like the dengue, then adenovirus, then those organisms which are intracellular like enteric, salmonella, all these, if they are suffering, and third version leptospira, they can lead to. Those who are already having genetic predisposition, then they are likely to have this type of conditions. In EBV virus can lead to that. Certain malignancies can also have this type of complication and develop. And rheumatological conditions, if they continue, especially the systemic juvenile idiopathic arthritis, or there is a SLE, they are more likely to
So
develop.
essentially, always some kind of a immune dysregulation. That's what Dr. Ambedkar used to use, that terminology. It could be malignancy which has got immune dysregulation. It could be connective tissue disorder. It could be severe infection. It could be underlying HLH. So all those things are extremely susceptible. Himanshu, what are the common triggers?
Common triggers are again the basically those patient, especially in a season like in rainy season when the dengue is common. So some kind of infections and triggers mostly infective, non-infective wise rheumatological condition. A patient with the underlying rheumatological condition like a SLE or SOGIA on a treatment, and they over and above have some either the medicinal changes or they acquired some infection. This trigger can start the cascade of cytokine storm like that, sir. And even a hematological malignancy cases after chemo. If you don't mind, sir, just 2 days back only, a child on a third, fourth cycle of chemo, adolescent boy, in febrile neutropenia 10 days back, typical sepsis, pneumonia, responded to the antibiotics, afebrile, and fifth day, he becomes suddenly started dull and only one fever spike. We suspected that cytokine storm because he was leaky capillaries and tachypnea. His ferritin came to 17,000. Just I have taken photographs. So all malignancies, rheumatological, over and above when they have some triggers, either a chemotherapy or infection, that are the most common things.
Perfect.
Yeah.
Miraj, you want to say something?
The same thing, I will make it simple. Two sets of patient. One is immune competent, one is some immune dysregulation.
So immune dysregulation.
So either the commonest trigger is infection.
Perfect.
Both the set of commonest infection, either viral or non-viral.
So Miraj, you tell us how do they present?
Well,
When do
very
you suspect
interesting
them?
because here as an intensivist we are fixed between the two, Dale and the devil, whether it is sepsis or no sepsis. So having said that, any child, what we say, any child who is not fitting in the natural course of illness, you have to think in that way. Number one. So on first hit and second hit, you expect the first hit, you see it, everything is going way, and then second hit comes in, or there is an unexplained fever, high degree fever, unexplained inflammatory response. So in this set of patient, I will have high index of suspicion with regard to this entity. And this is the way this is clinical. And if along with the clinical, if I'm monitoring lab wise, if by cytopenia, unexplained rise of ESR or CRP is not coming down, if these 2-3 things are there, I will keep my antenna high on the card for this kind of entity. Because earlier the identified, earlier the intervention, better the outcome.
Raju sir, you want to add something?
So normally in such condition, as very rightly pointed out, that any patient who had started recovering and was showing some improvement even biochemically, but then starts worsening. And in those patients, if you look at the inflammatory markers which are going high, probably is the time that you have to suspect and think that probably this child is going for a cytokine storm and start acting.
So basically, I keep recalling our teacher who used to categorize the disease onset as acute, hyperacute, subacute, and chronic. So immunological conditions are acute or hyperacute. So other condition being, it could be a vascular condition, traumatic condition, toxic condition, and immunological. So anaphylaxis is acute conditions. I recall one case which again was hospitalized with us for a PO for almost 2 weeks with some plus minus findings in the CSF, encephalopathy and all, seen in the morning at 9 o'clock by our neurologist, doing everything fine. Morning counts were done for some reason, bang normal. 11 o'clock had a very high grade fever, 102, 103, landed with refractory shock. We revived him, but at 1 o'clock, within 2 hours, he was brain death. And we happened to do his morning platelet count was 2 lakh, and at that point, after 2 or 3 hours, it was 20,000. His cytokine, his ferritin level was 40,000. So they can come. So hyperacute or acute presentation in a potentially sick child of that kind, you always think of macrophage activation or HLH. Now, Himanshu, what are the diagnostic criteria?
There
What
is
do you
no
diagnose?
typical uniform diagnostic criteria, but the, two things we have to see. First is the clinical criteria and other are the lab criteria. So in a clinical criteria, hallmark most common is the persistence of fever, non-responding fever, along with bicytopenia, then even organomegaly may or may not be there. with end organ dysfunction depend on which systems are affected. So hemodynamic stability, instability, and even a respiratory system involvement like tachypnea, oxygen requirement. So end organ dysfunction along with the vitals changes, especially fever is a hallmark. In a lab, we have to categorize three things. First is the to rule out the sepsis. So CBC along with the cultures and all that, main inflammatory marker ESR, CRP and ferritin. Ferritin is only one take-home message that we have to remember during this talk, that this is the most easily available, fastest possible marker, and other lab tests to again confirm the end organ involvement like SGPT, creatinine, coagulation profile and all that. So clinical features and lab. Clinical besides
Perfect.
lab,
So-
ferritin most common, yes.
I agree. Our understanding is increasing day by day. We are not kind of compartmentalizing into a thing. So HLH protocol 2004, which came previously, was mentioning about 8 criteria, of which 5 should be positive. But then we have gone beyond that. So of those 8 criteria, it was fever, bicytopenia, splenomegaly, then your ferritin and these things, then CD25, NK cell activity, genetics, and so those are 8, of which 5. But those genetics ones we don't have access. So we believe in those 3 or 4 criteria with a clinical background. Raju sir, you wanted to add something?
No, the same thing that till, I mean, 2004 diagnostic criteria were, and they have added. But for us in routine practice, there are limited, and what Himanshu has brought out, I think if we follow that, we can definitely suspect and diagnose the condition.
But my next question here, Himanshu or Minaz, you can take it. We have those criteria, like if case goes to hematologist, he calls it as macrophage, he calls it HLH. It goes to rheumatology, it causes a macrophage activation. Why this difference? And why even their cutoff numbers are also different? Hematologist says my number is 500 for ferritin, and rheumatologist says my number is 683 for ferritin. Why this difference? Why they are struggling?
Actually, sir, depend on the trigger or etiology for the cytokine storm. So when the cytokine storm is triggered by infective process, the level of ferritin may not be so high.
Absolutely.
Similarly, when we encounter the cytokine storm in a rheumatological condition, a child with Sogia or SLE, in them the ferritin may be sky high.
Perfect.
So there is a, basically message is that there is a different pathophysiological mechanism converging to a common diagnosis. So there is a different criteria and there is very difficult to form a uniform guideline for that same thing, sir.
Right.
Again, for us, ferritin more than 500 with high suspicion of cytokine storm. So ferritin cutoff value more than 500 to be considered. But suppose if it is in range of thousands, like 5,000, 10,000, 10,000, it will strongly support us the cytokine storm. Along with the clinical criteria must to be fulfilled.
So when we talk about the ferritin levels, though we gave 500, 600, actually when the ferritin level is more than 2000, they said the sensitivity and specificity is about 40%. When it goes to more than 10,000, the specificity is almost 95% for this diagnosis. So higher the level. So you said 70,000, blindly I will start treatment. That's what comes to my next question. How do you manage it?
Yeah, before we go back, the last point, the previous one, sir.
Quick.
Yeah, quick, very quick. So why there is variability in the different criteria? As you rightly said, that the common process is the same, but in inflammatory, it's more of the inflammatory side. So our ferritin on the higher side. So process remains the same, but which predominates? Infective versus inflammatory. What is the process which is predominant? Accordingly, the response will be there. So with regard to management, the next one is the management remains the same in the sense there are 3 ways of managing. Number 1, stabilizing the child. A, B, C. Number 2, organ dysfunction stabilization, whether it is hemodynamic, respiratory, encephalopathy, or renal failure accordingly. And number 3 is infection control, if it is infection control.
Source control.
So if you don't take care of infection, whether it is anti-infective therapy or source control, it has to be there. So infection control, organ stabilization, and important is immune modulation. So once we think it is immune dysregulation, so immune modulation. So we have the various ways of immune modulation. Accordingly, we have to proceed. So this is the way I will go about in brief.
Perfect. So he said stabilize the child, control the trigger, control the support the organs, right? So
Yes,
the gross
In
headings,
brief,
we will
in
not
brief.
go into details
Yes,
of it.
in
We will
brief.
be going further.
Yeah.
So in that treatment line,
Yeah.
what are the various treatment modalities you have?
Well, I will come to anti-inflammatory modalities. Okay, infection control and hemodynamics.
Infection control, leave
Yeah.
it. Organ support, you leave it. Come to HLH specific
Inflammatory
management.
modalities, in the way that we go about, number one is steroids. So we have different types of steroids. We can use methylprednisolone, we can use dexamethasone. Doses are variable. Okay, that's number one. Number two, IVIG. So methylprednisolone, IVIG. Then if it is not working, then you have biologics. So all those maps, tocilizumab, infliximab, and a very important is anakinra, subject to availability and the cost. So those are the lines of treatment. Along with that, sometimes we do go for plasma exchange, where we remove the cytokines. So you remove all the circulating cytokine, which is possible with the plasma exchange. So these are the intensive care therapy with regard to the removal of the cytokines. So this is the way we go about.
This is one condition where time is money.
Yes, time is
Faster
very
you react,
justifiable.
more the
Justifiable.
survival.
Yeah.
So IVIG, steroids, everything I'll push very fast.
Yes.
If I have access to biologicals,
We'll go for
which may not be. So I think Himanshu will be agree with anakinra more than tocilizumab. Am I right, Himanshu? Please.
So basically, first line steroids, easily available, fast acting, along with IVIG may or may not be needed. Second thing, proven cytokine storm with relative non-infective cause. In that, anakinra, IL-1 receptor antagonist, excellent result. We have discussed the case last year, 2 cases, superb response. And second, tocilizumab, everyone is aware in a COVID-related cytokine storm. So these two. One more modality that we already just discussed 2 minutes back, that is, if available, go for plasma exchange in a critically ill child.
Absolutely.
Critically, level 3 care,
Absolutely.
very high intensity cytokine storm plasma exchange, we can easily do now almost all center. And advanced center, a cytosob for cytokine removal.
In a recent time, there is a paper published in which when they gave all 4 together, the survival documented is almost 100%.
Yes.
Done within 12 hours.
Yes,
So
yes.
IVIG, steroids, anakinra and plasma exchange.
Yeah.
Of course, they would do plasma exchange first and then would give anakinra. That's one thing. And just slight variation, those are coming with more of a CNS presentation than the PNS. They would prefer DEXA because DEXA has got a better CNS penetration.
Penetrates CNS.
Yeah. So, Dr. Raju sir, I want to be fast now because we have got only 8 or 10 minutes. So, sometimes you don't have a diagnosis to prove. Is empirical treatment justified in a given emergency?
Yeah, definitely, because these are the conditions where you have to act very fast. And when you have to, it's a question of fighting against the time. If you are late, there will be so much damage to the body, there will be multi-organ involvement, and it will be difficult to survive. And even if survive, there will be some sequelae. So it is better that when there is a suspicion, try to get the important investigation and start working.
Start
acting
with
there.
maybe 30 milligram per kilogram methylprednisolone first pulsing, and then think of IVIG. That's not going to cause any harm, and then you can work out. If you have really high suspect of HLH, then you collect a bone marrow quickly and give all those things. Fine. What response do you expect, Minaj, to your therapy?
Yeah, there are 2 ways of response analysis. Number 1 is clinical, number 2 is lab. So I will straightway go for clinical. Number 1, fever. The defervescence of fever, number 1. Number 2 is improvement in organ dysfunctions. If I am a patient who has hemodynamic instability, stable hemodynamics. Hepatopathy, improvement in the SGOT, SGPT. Coagulopathy, improvement. So all those organ dysfunctions which are affected are improvement, though clinical. And with regard to labs, I will only stick to 2 or 3. The most important is ferritin. If the ferritin shows downward strain, if my CRP is showing downward strain, I am on the right pathway. So even if the fever is there, but I will wait for fever to come down, there's a defervescence fever, that's the clinical response. That's all.
So clinical response and ferritin monitoring, which would be done very aggressively, generally would do the ferritin after 48 hours first ferritin. If that is showing a good improvement,
Absolutely.
rest of the parameters, if they are stable enough, you should go ahead with that. We have already discussed about various other modalities. So let's move to the last question. Himanshu, how do you prognosticate? The parents, what are you going to tell them?
Sir, prognosis is depend on at what time we earlier the diagnose, faster we act, the excellent prognosis. The delay in a diagnosis or delay in a treatment may worsen. So it is a very dicey thing. Early diagnosis and management intervention are most important. But in an infection trigger cytokine storm, the response again is excellent. And the good prognosis, they recover and respond very well. While in a case of like underlying rheumatological or malignancy, they require long-term management and the prognosis we may not be sure, sir. So
Obviously-
early diagnosis, timely action and infection triggered cytokine storm, excellent response. And in a pediatrics, mostly we encounter this first category more than others. Yeah.
So most of them who are coming after 5 to 7 years, we are probably acquired HLH kind of rheumatological. They have that transient, but those are coming early first year or something.
Yeah,
We'll have to
early
investigate
infancy,
genetically.
genetic predisposed type of children, the prognosis will not be that good.
Absolutely.
Probably
Rule out
they will
underlying malignancy,
need,
a genetic HLH.
Yeah,
That will, because if
so
he's
they
the
will
first,
need
first
the
attack of
transplant, so
cytokine
that's-
storm in a HLH, then you will be quickly landing up with bone marrow transplant. Otherwise, you'll land with the next attack, which will be killing him. So I think that's very important point you said.
Yeah,
Yes.
I want to make only one point. As you rightly said in the beginning, if you think give first dose of steroids, there is no harm. We always say infection बढ़ जाएगा, infection कम होगा. No. If you think in this direction, give first dose and then rethink whether I am right or wrong. But you know, time is important.
Only Minaz,
Yes.
if you have an abscess, then collect a bone marrow and
Yes,
then give
yes,
it.
that's
the
been
only
done. Yes,
advice.
yes.
Otherwise, giving one dose.
There's one dose steroid will not cause
Let's
harm. It will in
quickly
fact help
go
the
through
health.
one very interesting
Yeah,
case, and
yes.
I want your quick answers because this is a good take-home case. This is an 11-month-old baby who presented with intermittent fever for 1.5 months, joint swelling for 20 days. There was no COX contact in this child. He was treated at local hospital with IV antibiotics for 2 weeks without any response. Now, this child, when he came, hemodynamically was stable. He had hepatosplenomegaly, which was about moderate. Ankle synovial swelling was there in this child. Do you need any more information quickly? And what is the thought process? So, Raju sir, please.
Yeah, this looks like some rheumatological disorder, inflammatory disorder. I mean, looking at the clinical picture, probably it is the systemic onset GIA that we normally expect because the
Yes.
ideal age is after 1 to 4 years that we normally
Sir,
see.
we also
But
thought the
even
same
at
way,
11
but evolved in a very interesting fashion. That's the reason I'm presenting. I'm sure I won't present a very straightforward case since we are finishing the session.
I understand that.
So, will you comment on these counts?
This is very interesting. You know, there is a hemoglobin which is dropping and platelet count is increasing. So anything with in the sepsis, the platelet should go down. Here the platelet is going up. So platelet is going up. Most likely it is not infective. It is non-infective cause of, the reason fever and all those things. And again, we have a CRP and the ES on the higher side. So it goes more in favor of inflammation.
All of you agree? Both of you agree with this statement? Raju sir, please.
It's more of an inflammation, not infection. I would still say it is an inflammation only. That's it.
Fine. So, his workup. His blood culture was negative. Then we had Will Felix available. This case I have seen about 5 years ago. Leptospira was negative. Brucella agglutination was weakly positive in this child. Unpasteurized milk history was there in this child. Hepatitis ABC, because he had liver dysfunction, we did that. His COX workup, no COX contact, were basically normal. PU workup, CT, chest and abdomen was normal. Nothing was there in that. Himanshu?
Still, workup wise,
His unpasteurized milk history, coming from a village place.
giving the antibiotic to cover the brucella as it is.
No, we have not given an antibiotic and he has reserved some sporadic 4 दिन 8 दिन ये करके आया है और क्या ऑगमेंटिन खाया रहेगा एडमिट तो नहीं किया था अभी तक
And further workup to find the
what brucella this is very interesting.
okay.
So we initially thought it's a systemic onset JIA. So before starting, basic 2 investigations are mandatory. One is bone marrow and second is echo.
Echo, yeah.
So bone marrow was normal and echo showed vegetations on the mitral wall. Now you have a PO, we have got a synovitis, we have got organomegaly, weakly positive brucella and myocardial vegetations.
So this could be brucella still because a multi-system involved brucella is known for that.
Absolutely. So we sent 3 sets of blood culture with a prolonged incubation because a brucella takes 2 to 3 weeks to
Yeah,
incubate.
2 to 3 weeks.
So we had sent the initial one which was reported within 3 days, 5 days as negative. We collected 6 samples, 3 sets, prolonged intubation for 2 weeks. Meanwhile, we got a cardiologist opinion. It looks infective endocarditis, but the age group unusual. At
Very
1 year wise, there is no underlying heart disease.
With
So
no
why to think of? History of consumption of unpasteurized milk, possibility of brucella. We took a ID opinion on this, started on ceftriaxone, gentamicin, rifampicin, and added co-trimoxazole with a senior ID person, right? So everything was started. He responded. The fever started coming down. For next 3 to 4 days, there was no fever, just to restart again after 4 days.
Oh.
And now started high spiking fever. So what next?
I think it is a time that we now try to find out whether there is some type of hyperinflammation disease developing or not. Because this.
But is the brucella known to cause that?
I mean, brucella is not known, but any infection can cause. So we have trigger. So we have to keep that in mind. And in such a case where there is some continuous disease, initially it was, and then, some improvement and then worsening. So in those we must try to
on
find
day
out.
15, I'll just take 2 or 3 minutes. Yeah. So now his 15th day of hospitalization. High fever continues for reoccurrence fever lasts about 4 or 5 days. There is new onset macular rash on the body, progresses all over the trunk and becomes dark brown, and this is a child. What is it?
It's difficult to just say from the clinical picture.
Yeah.
But something which has, I think, infected the.
Anything else? My panelists don't know the case. Let me tell you. My panelists, it's very gutsy to sit there on that dais without knowing the case. So big, loud applause for them that they accepted to take this case.
Some involvement of adrenal and causing this type of change.
Sorry, sir?
Adrenal involvement and causing change. That
Okay, yes.
One of the cause.
Platelets. I'm coming to the investigation. What investigation you want?
This is some, again, immunological thing which is affecting the
In fact, this gave us a clue.
T-cell related
This one
reaction,
gave us a clue.
drug related something.
Good idea. But this gave us a clue because my original thinking was still connective tissue disorder. Brucella came because of that weak positive.
Yeah, that was
Okay,
false positive.
now we just shut down that question, and had I been SOGI with this was macrophage activation, histiocytosis. There are histiocytes here.
Yeah.
So wherever there are macrophages, they will work. They are on the skin, they are in the lungs, they are in the brain, they are in the liver. So this is what.
Histiocytosis.
So this is the investigation set we did, suspecting that the CRP was sky high, ESR high, ferritin was 70,000, fibrin is 154. This was a macrophage activation, and now we confirmed our diagnosis, and that endocarditis was actually a marantic endocarditis, which is a known case, a rare case. In a SOGIA, you can have marantic endocarditis because of inflammation. You got endocardial erosion,
Damage.
where platelet can, you are hyperplatelet condition, so they make a clot. So known condition. So this child was followed up following a steroid activation. He responded very well. Fever subsided, serum ferritin 70,000 to 47,000. He required only methylprednisolone pulsing. This was a SOGI followed by. So sometimes those odd brucella, mild positive can really baffle you and take you for a ride. Fortunately, we have got in-house rheumato-immunology department also, so that helps. And that's how. So friends, to summarize, cytokine storm is not so uncommon and can pose serious emergence. I am sure everybody sitting in this hall practicing more than 2 or 3 years must have seen at least one case of cytokine storm in the practice. It's not rare at all. Cytokine storm can complicate any immune dysregulation disorder like infection, malignancy, immunodeficiency, connective tissue disorder. I'm sure we are seeing all these conditions left, right, and center, especially with suddenly adenovirus going up, upcoming dengue fever. Keep this in the background. Unexpected deterioration in a febrile child with bicytopenia with new onset organ dysfunction. I said unexpected. You're not expecting that thing. So think of cytokine storm, and high index of suspicion, aggressive investigation, emergent supportive and specific therapy can lead to a good outcome. Thank you very much for the patient listening.